Welcome to Educators Podcast. My name is Swapnil and work as an intensivist at St. George Hospital in Sydney. Today it's my great pleasure to welcome two very special guests from Penn State. First guest is Daniel Wolpaw. He is a professor of medicine and humanities at Penn State College of Medicine and works as a general internist with a career focus on medical education and the humanities in medicine. He is currently serving as a curriculum design lead and co-director of the University Park curriculum and also act as a co-director of the College of Medicine Junior Faculty Development Program. Before moving to Penn State, he served on the faculty at CWRU for almost 30 years, where he was one of the architects of the 2006 curriculum transformation, director of undergraduate clinical education, and creator and director of the Scholarship in Teaching Awards program. He is an honorary research fellow at the International Research Center in Medical Education at the University of Tokyo, where he has spent extended periods of time as a visiting professor in medical education. And he's also a long-time contributor to Harvard Massey program for educators in health professions. His areas of interest include curriculum development, critical and systems thinking, adaptive expertise, and professional identity formation. And the second guest is his better half, Dr. Terry Wolpaw. She is a professor of medicine and the vice dean for the educational affairs at Penn State Hershey College of Medicine and a faculty member in the Division of Rheumatology. With her broad education portfolio, she has the opportunity to impact on education from entry to medical school through ongoing professional development for the practicing physician. Terry is a recognized national leader in medical education. She was the recipient of one of the first American College of Rheumatology Clinician Scholar Educator Awards. She has served on the Association Education Committee and chaired its Continuing Assessment, Review and Evaluation Committee. Terry has completed a master's degree in health professional education at the University of Illinois at Chicago. Her research focused on the expression of clinical reasoning and uncertainties in case presentations. She has developed the SNAPS technique for case presentation to preceptors based on experiential learning theory. This was validated learner-centered case presentation method which serves as an efficient cognitive forcing strategy for the expression of clinical reasoning during the case presentations. It is used with the medical students, residents, and physician assistant students, both nationally and internationally. Terry brings her experience in curriculum change, a track record of scholarship, and a commitment to collaborative educational design with health system and community leaders to her work at Penn State and to national initiatives on improving outcomes for learners and for patient care in the clinical setting where they learn. It's my great pleasure to welcome Dan and Terry. Welcome, Dan. Welcome, Terry.
Thank you.
Thanks very much.
Today we are going to talk about a topic which is very close to your heart, that is design thinking in medical education. Can you tell us more about this novel concept?
Sure. Design thinking is a concept that's been it has been used for some time, other professional areas. But I think over the last 10 years ago has been getting traction in education and in medical education. I know that Olin College of Engineering used it to design a course when they started their engineering school about 15 or 16 years ago, and designed a course called User-Oriented Collaborative Design. And since then, I think this has been making headway. To me, it's a kind of an expanded form of backwards curriculum design, where you look at the outcomes that you're interested in, and then kind of back design the curriculum. And basically, in design thinking, it begins with a concept called empathy, which is looking at your end users and your outcomes, and trying to gain insights into what opportunities there may be to develop the curriculum that you think would best serve those goals, and then begin to explore those opportunities through rapid prototyping, developing a variety of interventions that may achieve those outcomes, looking at the results of those prototypes, and then doing reassessing and reengineering and going through cycles that I think we're all familiar with from various other endeavors. But I think the key is looking at a variety of perspectives on what the outcomes are that you might be interested in. And in medical education, clearly there are a variety of stakeholders. It's not just what students are looking for. We have what patients are looking for in terms of the doctors and other healthcare workers who come out of the process of medical education. And there are the system, the employers, who will be bringing people into their workplaces. What are they looking for? So it's a range of perspectives. It begins with this process that has often been called empathy, which is really connecting with the perspectives of people who will be using the system and who will be intersecting with the people who are coming out of your program. So I'll stop and let Terry.
Sure.
Yep. I think Dan said it really well. I think that design thinking comes out of, as Dan said, other fields, particularly I think architecture as well. And it's just a real opportunity, I think, to bring in often on your design thinking team people who have perspectives very different from one's own. So in medical education these days, I think people, for sure, health system leaders are among those people on the team. But I think we're also seeing the incredible opportunity when we bring in people like engineers, architects, patients, families, and certainly the different stakeholders that Dan's mentioned as well. But I think particularly bringing in a whole variety of people that can look at healthcare design, and the way we need to educate for that design in 21st century ways.
Okay, so as you mentioned, this concept initiated in engineering world, and now it's kind of slowly moving into the healthcare sector. Now, you implemented this novel concept in Penn State Health. Can you please tell us how you did it and what was the motivation for doing it?
So I think that this really, for us, began with a very fundamental understanding, which was that medical care has changed enormously in the last 100 years, since the first Flexner report. And medical education actually hasn't changed very much. And so there was a really, for us, this kind of insight that medical education needed very much to be much better aligned with today and tomorrow's healthcare system, that we somehow needed to really understand the users today. And then, as Dan said, in many ways, then design medical education so that we can be sure that the students that are going to medical school and investing incredible amounts of energy and thought and time and learning are in fact going to be developing and gaining the skill set that's going to be needed when they have their first job in the healthcare system, often 10 years or more from the time they walk in the door of medical school. So that was really, I think, for us, much of the reason for doing it.
Yeah, I think I agree completely. I guess I would add that it's also, I think, given us an opportunity to take a hard look at what we're doing and why we're doing it. There's a lot of things that we do in medical education, just like in other fields, that are just moving forward because of just because of the tradition of doing it in a certain way, and in some cases, I think we've lost sight of what it is we're actually trying to accomplish. So some of what we're trying to accomplish, as Terry says, has really changed and evolved, but some of it needs reassessment in any case. I mean, we've learned a lot about education since over the last 100 years and how people best learn. And some of that was known 100 years ago, but didn't really get any traction in traditional educational programs. So there are a lot of things in the mix, both in terms of how we teach, as well as what we teach and who we are teaching and why we're teaching those things.
Okay, so and since you implemented this at Penn State, what are the positives that you will attribute to design thinking that you have seen so far?
Okay, so I think we've been introducing this in a variety of ways into the into our medical school and into our planning. Probably the most prominent um, uh, product of this for us has been in our regional campus at University Park, where we had the opportunity to rethink how we would go about creating a whole program of medical education. This has evolved over a period of time with a lot of input from a lot of people, but we were starting in a place where we didn't have a lot of baggage. We didn't have an entrenched faculty, and we had the opportunity to um, to have pretty much of a clean slate and look fresh at what we were trying to accomplish. And so we had a lot of discussions where we used design thinking principles to look at our outcomes. We had a we brought together education thinkers and leaders from across the country, and actually some from internationally as well, in a meeting which was organized around design thinking. Um, we had three groups whose homework before they came was to try to uncover the perspectives of patients and learners and employers in terms of what they were looking for in terms of outcomes of medical education. We put those groups together over a day in terms of discussions and prototyping, and then bringing our thoughts together. So that was a fairly concrete manifestation of design thinking that was applied to our program development. And then which Terry can say more about, we brought on some students who were admitted to medical school, but were willing to put off the start of their medical school for a year while they worked with us as we called student design partners, an idea that we developed from the work at Olin College. And Terry can say some more about that.
Yeah. So I think the positive for us in terms that we would attribute to design thinking is the opportunity to look fresh. I think that would be perhaps what I would call the greatest positive. And certainly the student design partner concept is one of those. I think that what has happened in medical education, certainly for us, but I would be willing to bet that this would be for others, is that we have gotten very much entrenched in this idea of what is the content we need for students to have. And we get so entrenched in that content that we forget what is the content they no longer need, or what is the new content or the new skill set. So I think the biggest positive for design thinking is really stopping, giving oneself some space, again, to think about that alignment between what we're doing in medical education and what they're going to need for their careers. And one of the ways to do that is to bring in people who do not have a sort of pre-molded perspective of how that should be. And that was what we did with the design partners. And as Dan said, learned from Olin. So these were, for us, five people who were admitted to Penn State College of Medicine, but had not yet started medical school. So they didn't know what medical school was going to be like. And we asked them to pause for a year before starting medical school, and we employed them to be our true design team partners along with the faculty and others. And that perspective, both in the meeting rooms where they shared in developing ideas, they were in the classroom where they tried out or road tested ideas. They were in the debrief rooms after that to tell us what worked and didn't work. That gave us incredible new eyes. Yes, our eyes were able to see things quite differently, I think, in terms of what today's learner needs in order to learn, and what today's learner needs in order to become the physician in tomorrow's healthcare system that's going to make a difference for the patients and for society.
Okay.
I just wanted to kind of reemphasize something that Terry said about our traditional view of how we create a curriculum. I think there's been an overwhelming attention for many, many years on what we need to teach. And I say that deliberately that way. There's a certain content that we need students to learn, and there hasn't been a lot of thought in terms of curating that, but that's been a focus. And then there's been a lot of emphasis on how we go about doing it, and to move away from lectures that's been going on for many, many years. Should we use PBL or TBL? And there's a lot of emphasis on learning strategies, but there hasn't been as much emphasis on why we're doing what we're doing and what we're trying to achieve when we do those things, and in fact what we are achieving. So the opportunity to use principles of design thinking, as Terry said, take a fresh look at that whole universe of how we go about our roles in medical education and how we go about doing medical education has been really important. And the design, the student design partners, I think were a really important part for us because they really essentially lived design thinking. They embodied design thinking in an important way. So for us, it was a strategy to put design thinking right into the mix of what we're doing and how we're doing it. And it was an investment on our part in doing that.
Sure. So that's quite interesting because often as the educator, we think that we know what is right for the students. But as you mentioned, that you kind of allowed students to decide what they want to learn within certain boundaries. What was the response of faculty and students within your institute to this change?
So I think I don't think I would say it that way. I don't think that we allowed students to decide what they were going to learn. We allowed students to into the room where we tried to figure out how to go about our learning experiences. And did some of that relate to the actual what of learning? Possibly to a small extent. But I think there was very little questioning up front that students need to learn certain things. They need to do it over a period of time. They know they have standardized tests they need to take, and they're very, very aware of that. I think this was more a reprioritization of things that happen in the course of medical education, largely around the context of learning, the process of learning in terms of not in terms of strategy like PBL or TBL, but in terms of how patient experiences fit into that, how student motivation and inquiry and student agency and empowerment play an important role in their education rather than being handed information that they need to learn. So I think it's those aspects that I think were very powerful for us rather than exactly what it is that in the end they wind up learning in a traditional sense.
And how did the faculty respond to this change?
So I think one of the key pieces here is that the key faculty in this program were working with these student design leaders simultaneously to create the curriculum. So it was really a co-creation of the curriculum. I think that is probably the most important answer there, that when one co-creates, one is also co-implementing, co-learning, co-quality improving. So the faculty were very much a part of this whole process that was taking place at our regional campus. So I would say the simple answer is they were very positive. There was an entire year with the student design partners, again, road testing, trying, making adjustments. So it was not as if suddenly there's this whole new curriculum. It was being sort of dropped down on them at all. It was really something that they were shaping and creating together with the student design partners, and then implementing together, and then making, what is always the case are those corrections as you move forward and you find that perhaps your direction isn't quite as taking you where you want it to go. So that was very positive. Now, the regional campus for Penn State is about 100 miles from the central campus at Hershey. And again, we work collaboratively, but we were thinking back and forth to make sure that we had appropriate comparability between our programs. Our accreditation, the Liaison Committee on Medical Education, does require, and it makes sense, that any student graduating from Penn State College of Medicine meets the competencies, the overall competencies of the college. So we were certainly working back and forth with our central faculty. And I think the answer there is that they were really interested, genuinely interested in this somewhat different kind of a way of working taking the students through, particularly the pre-clerkship part of the curriculum, which is where we are right now.
Yeah, I agree. I agree completely. The only thing I would add is that there are a lot of people on the faculty, and if they don't have the opportunity to have a direct discussion about this, then they may have various thoughts about it. As you can imagine, we have hundreds and hundreds of scientists and physicians on our faculty. But when you're able to sit down in a room, which we've had a lot of opportunity to do, and talk, as Terry mentioned, certainly the leadership, the faculty leadership of the curriculum have had a lot of opportunity to sit and talk about this, but also additional faculty in different venues. The response has been very positive, but it does take some work to have those conversations and to invite. We've also invited faculty from the main campus into the process, into the small group discussions, and that always makes a huge difference.
Okay. And will you be able to share some of the challenges that you faced during this process, and how did you navigate through them?
So I'll start with one, and then I'll let Dan take over. If design thinking often means that you are trying things that are you come up with ideas that are new or haven't been implemented. And it sometimes means that we have to recalibrate what a learner can or can't do. So I'm going to give you an example of one of the challenges. One of the parts of our new curriculum design for our regional campus, which is a subset of students, it's 12 students a year right now, is that these students have much more clinical experiences the day they walk in the door of medical school. So these students are in the office settings 3 half days a week, and then they're in the classroom the other days. What that meant was that students walking in the door of medical school were taking care of patients in ways that were appropriate at that time, and very quickly began to be capable of some of the patient care, blood pressure, taking a history, doing a perhaps initial examination that we often, at least in the United States, don't think of students as being ready for until much later in medical school. So one of the challenges was working with these different physician offices, patient care offices, to help them to rethink what a medical student is capable of in their office, and then to appropriately help the students to take on those responsibilities. And then over the course of the year, as the course of the first year of medical school, as a student got more and more skilled as a student clinician, to engage them in those roles.
I think that's a great example, and it really is part of a larger issue of, if you're going to, specifically for design, for student design partners, pretty much no one had any idea what we were talking about when we said student design partners. And partway through the year, we changed that to medical student design partners to give it a little more familiarity. But there are just a lot of logistical and cultural issues around those students and how they can interact and what they can be allowed to do. And you know, that's, we live in a world where you know, people have their lanes that they're in and the ways they think about things, and there's a certain amount of bureaucracy, and so that was challenging. I think that it's always a challenge to maintain ongoing open lines of communication about what you're thinking and why you're thinking it. it's especially when there's a lot of new things going on. It's sometimes things kind of make it from some planning discussion into the daily routine or into the planning that without enough discussion. And at the same time, students, even though they are relatively clean slates, our design partners had not been to medical school, but they still came with certain expectations and certain um, ideas about what they needed to be accomplishing and how over what period of time they needed to accomplish that. So there's a lot of we are in a culture of education that has overwhelmingly been in almost every aspect of education around content transmission, and to start to move that to move away from that and emphasize some of the things, and this came directly out of design thinking, because the things that patients care about and that employers care about are not necessarily related to content. And largely they're not. They're related to the skills and attitude and to the human interactions that go on, or to the ways that people function in teams and how they collaborate. So it's not that anyone wants professionals who don't know what they need to know and don't have the skills that they need. Everybody wants that, but it's kind of it's not enough all by itself, especially in today's world. There need to be greater understandings, greater goals in terms of how people function with each other and with teams, and with patients, and those things have in the past been pretty much assumed in medical education, that we assume that we will give people a lot of content and they'll figure out the rest of it. And it's just not good enough anymore. And we're graduating people who aren't able to function in the kinds of work environments that we want them to function in, and we need to kind of recalibrate.
I also think that one of the challenges is that when we're engaging in medical education change, inevitably we need to move ourselves out of our comfort zone, and that's not easy, and that has challenges. And I think that for the leaders, and that would be particularly for Dan and me, holding people in that period of disequilibrium as this new skill set is being learned not only by the students but by the faculty, and knowing that there's going to be inevitably this time out of discomfort, new learning. It is really a challenge, I think, but that's what comes with being willing to look at things in new ways and better understand what needs to happen today, again, in medical education, when we're always educating learners, not for today, but for tomorrow.
That's so true. And my question is on kind of on similar line, that nowadays I noticed that a lot of focus is from both faculty and student is to achieve the good grades, which is kind of important for career progression. But also there is a notion that the person who achieves the higher grades is kind of a better doctor. Do you think that design thinking helps to challenge this dogma or helps to change this thinking?
Well, I'm going to talk about grades in the United States medical schools, and I don't know whether this translates as much to other places, but at least in the United States, there is the National Board of Medical Education examinations, the STEP exams, the USMLE STEP exams, unfortunately have become so high stakes in terms of the choice of residencies that achieving high scores on those is very much on the students' minds. And it would be an error for me not to say that. Making sure that the students gain the skill set and the habits of mind to be physicians of tomorrow and physicians, over their professional lifespan is another goal. And those two goals sometimes come together, but frequently do run in parallel. So what I think is is to acknowledge to the students that yes, making sure that you have the content you need to achieve high scores on the examinations is important. Simultaneously, it is really important that you develop the kind of clinical reasoning, critical thinking, scaffolding for future learning, for asking questions, and for developing answers to questions you may not immediately know the answer to, because that's really the life of a physician. And I also think that when we talk about grades, we do have to remember that the information uncovering medical errors today is really showing that the physician's errors are often in thinking and reasoning, and that sometimes is not necessarily about cramming for that multiple choice exam to get the good grade.
So I think that's a great way to describe this. I want to come back to something I said earlier, is that we tend to load content and assume other things. And the fact is that the things that we assume don't necessarily happen and are really important. The ways people function in teams, the way they function with other people, the way they continue to ask questions, all the things that we've talked about, that Terry just talked about. We need to kind of look once again at the world we're living in, where information comes from. And there are a couple things about that. One is, when you emphasize the process of critical thinking and systems thinking and things like that, you have to think about something. And when you're talking about patients come in with a variety of concerns and problems, and you need to dig into those. The question is not whether you're going to acquire the content at some point or another. The question is how that content relates to the student's ability to kind of take it and move on with it, relates to the student's motivation in learning and in digging into that content in the first place. There are a lot of really key aspects to learning, and we're not for a moment questioning that. Number one, students do have expectations of learning and content that will impact whether it's grades or whether it's test scores. It will impact that sooner or later. But we also feel and have increasing evidence that if students are motivated to learn and they work hard to learn, that they will in fact learn, and that they will be well prepared to learn what they need to learn for these exams. And we need to give them the time and the opportunity, the space and the curriculum to accomplish all these different things, but keeping our eye on the ball of who is this person that we want knowing, and not just what is it that they know. I think, we need, as Terry said, people who are asking questions. We need people who know when they need to ask a question. We need them to be able to ask questions, and we need them to critically think about what is the information they're getting back. We live in a world of voluminous information, and the question is not learning all that information. The question is really learning how to apply that information.
I think that design thinking doesn't really challenge the dogma of students wanting to achieve good grades. I think instead what it does is it understands how to accomplish that. Because, again, one of the first steps in design thinking is to empathize with the end users. And the students are an end user. Again, the healthcare system is an end user. The faculty are end users. And so design thinking, I think, lets us simultaneously look at multiple outcomes, and then to create a design that can get us not to just one outcome like good grades, but to get to the multiple outcomes that we need for tomorrow's physicians.
Yeah, it's kind of recalibrating our outcomes and our priorities.
Okay, great. I think that the way in which you put it together, that was really good. Now, I want to ask, there are a lot of upcoming educators who might want to try this novel concept if they're undergoing through the curriculum reform process. What are the resources out there that they can use?
I think that there's an incredible literature out there at this point. So certainly, just a literature search of design thinking will uncover many YouTube videos of people that say this very well. For us, the Stanford Design School and some of the different resources that they provided were really important to us in understanding the steps. And then I think there are a couple thoughts that I have. One is that to be able to contact someone and work with them who has done the process would also be really helpful. So as we did this, as Dan said, in our summit, our education summit with people across the country, we were very fortunate to engage some of the leadership from the Harvard Macy program for educators in the health professions. So both Dr. Elizabeth Armstrong and Dr. Connie Bowe were very helpful for us. So I think both reading and then really being willing to have somebody who can facilitate the process to bring people with diverse opinions together and move them through what was often days, in our case, a couple days of thinking is very important.
I think I agree completely with the resources. I think that it's also important to have to go into this with an approach that, kind of everything is on the table, that you're going to take a fresh look. Terry talked about this earlier, that you're going to look at what you're doing with fresh eyes. That you may have a variety of compromises and limitations based on resources and local situations. But at least you need to start someplace that gives you the opportunity to re-envision what it is you're doing and why you're doing it, which is what design thinking in the end does. It gives you that opportunity. And I think it doesn't take a lot of resources to take advantage of that opportunity. How it sorts out, how you wind up where you wind up in terms of your curriculum, in any or your medical school approach to things, that's going to vary, and there are a lot of complex influences on that. But I think this is an opportunity to kind of operationalize. I'm fond of thinking of the Zen concept of beginner's mind, Shoshin as the Japanese word for it. But basically, that you can start with a beginner's mind, and in design thinking, that's specifically not just with your mind, but with the minds of this whole host of other people who have a stake and have interest and have important perspectives.
Yeah, I think the resources are both what we might think of in terms of the literature and certainly other people who have gone through it. But there's another really important resource, and those are the people that you bring to your design table. And as Dan just said, and I would emphasize that really maybe the most important resource that one taps into are the resources you haven't tapped into before. We typically do curriculum design by getting the teachers together and start, thinking what we want to do differently. And that is very different from design thinking. In design thinking, you bring together many perspectives, often perspectives you've never heard from before. And then the greatest resource is really having those individuals go to the end users to try to, again, empathize and understand what they're thinking. So the resources are often the people at the table, and bringing them together, bringing a sufficient diversity of those individuals together, and then shaping the opportunity for them to look hard and understand the end users. Those are the resources in many ways.
This whole concept sounds really very cool, but it's still not very widely accepted. Still, there are a lot of very famous universities out there who have not adopted this concept. What is the reason behind this?
Again, I'm going to speak to Harvard Macy. One of the things that I still remember learning about is change, and that one can engage in sort of technical change or in transformational change. And the reason that I think perhaps this is not widely accepted is that, quite honestly, most of the time, I think when we're making changes, we're talking more about technical changes. We're really trying to kind of leave what we have in place and, changing the order, changing the length of classes, shifting up some active learning, but still a big classroom. So technical changes, and those are very important. It is not to underestimate that. But there are times when the change needs to be more than that. It needs to be a transformational change, a real change in the underlying conceptual framework of what we're thinking about. And that, I think, the reason that design thinking may be not that common or not that widely accepted is, one, we don't that often undertake technical change, and it's really hard and takes a lot of time.
Yeah, I think that it's just too easy to not do this. It's too easy to be, in quotes, innovative by introducing a new strategy, a new kind of pedagogy, and not kind of do the transformational rethinking that Terry talked about. I think you just that gets back to the being willing to look at it with fresh eyes, um, and that's not all an individual problem. I think institutions often don't want to make that in kind of overall investment in people, time, and resources to do that. They don't necessarily apply the kind of vision they need to apply to the whole process. So it's like a lot of things. It's there has to be a willingness to kind of get out there and understand that it's really in some ways a willingness to use systems thinking. I would say look at the big picture and look at what you're doing that's perpetuating things that you may not think are the best things. Bob Keegan has written a lot about immunity to change, and I think those kind of concepts really apply when it comes to why these things don't get a lot of traction all the time.
Okay. I hope that after listening to this podcast, at least the new educators out there will start thinking about this concept and probably start the conversation out there. Now, the last but most important, what's your advice to budding educators?
So I would say connect with other people who are thinking about this and working on it. Talk to people. Read outside of things that you ordinarily read. Maybe it's reading about educational efforts in the design world or in engineering or in some other field. But I think a lot of it's around people and looking for people who can come and kind of help get things started, help you look at things in a new way. Maybe people who will help the institution, give you some credibility in the institution to embark on a new pathway. I think, but it just has to do with, to a large extent, creating the time and the space and the motivation to just take a hard look at what we're doing and why we're doing it and what the alternatives are and look for people who can help you to move that forward.
My advice would be when engaging in curriculum change, look for people who aren't like you and bring them to the design table. That's my first piece. And my second piece is when you and people not like you go to those end users and try to empathize with the students and the leaders of the healthcare system and the patients, listen. Open your ears and listen, because I believe they have a lot to tell us. And we have been so kind of shaped by our own views for so long that maybe we just haven't been listening as hard as we've needed to.
I think there are a lot of things that we think are kind of immutable, they're unchangeable, they're at the core, whatever words you want to describe, that probably aren't. And I think that it's kind of this, once again, it's fresh eyes, it's everything's on the table. Let me look for support where I can get it, but let me step back and question things that I've always kind of assumed to be true, and look for ideas and support. And as Terry said, the people that don't think like you, that have a different perspective.
And then I would just add what I say probably almost daily at Penn State in my role as the Vice Dean for Educational Affairs. Change is hard, and change is a long process. I many times quote Carol Bland's article on change in medical education and talk about how it's a 10-year process. and that we need when we undertake this kind of transformational change to be ready for hard work and be ready for a long process.
Now, Dan, as you mentioned, if go out and connect with your peers, your colleagues, or experts. If listener wants to connect with both of you for any questions or any tips, what's your best contact details?
So my email is I can say it, but that's probably the best way to contact me. It's dwolpaw at pennstatehealth.psu.edu.
And mine is T Wolpaw at Penn State Health, all one word, .psu.edu. Those would be that would probably be the ideal way to begin, and I think both Dan and I would be, more than happy to engage in a conversation as we're having today with anyone who would like to explore this in more depth.
Thanks, Dan. Thanks, Terry. Thanks a lot for your valuable time and all the information that you shared with us today. It's incredible that the job that you're doing at your institute, and I hope that that will inspire the change in other institutes as well.
Thank you. It's been a pleasure talking to you.
Thanks so much.
Right.